Welcome, everyone. This is the second in our series of implementation videos for residential redesign. My name is Carla Licio, and I'm from the National Center on Addiction and Substance Abuse and the Managed Care Technical Assistance Center. Today, this video is going to cover clinical implementation, and we're going to hear from two providers who are on the leading edge of this implementation process. With me today, I have Pat Lincourt.
Hello, I'm Pat Lincourt. I am the Director of Practice Innovation and Care Management at OASAS. I'm really happy to be here with Carla and to be here with the providers who have been out in front in implementing residential redesign. OASAS is really excited about the opportunities brought to the system through residential redesign, and we are learning from the early implementers of this, particularly on the clinical side. I'm excited to hear about some of the ways that the residential programs have been able to bring in medical and clinical staff together to create a stabilization element within residential care, as well as rehab and reintegration elements. And so you're going to hear from two of the people who have been out front on this redesign, and I'm going to turn it over to them. Thanks.
Hi, my name is Paige Prentice, and I'm Senior Vice President for Horizon Health Services, and I'm here with Kathy Sareski, and we're going to talk about the clinical aspects of the 820 residential redesign implementation.
Hi, my name is Kathy Sareski. I'm the Vice President of Restart for Catholic Family Center in Rochester, New York, and I look forward to having this dialogue with you about the clinical implementation.
Yeah, so, Kathy, I think honestly, when we talk about the whole 820 implementation and getting that going in a positive direction, I think it absolutely has to start with staff buy-in, right? Because they're doing the work for you and they have to buy into that whole process.
That's very helpful. We also did a very similar thing, and as soon as we knew that this option would become available, we started having conversations with our staff, especially in large forums where there could be some dialogue, some sharing of questions, so that people could start putting out there what it might be. And I think the other thing that helped us at the very beginning was to recognize that we would have staff that have worked in this field for a very, very long time, become very comfortable, very familiar with the existing levels of care,
right,
and might struggle initially. So we sort of developed a plan for how to engage the staff, and little by little started to roll that out as we came closer to understanding what levels and elements we would incorporate. Would have more and more conversation. And then, of course, as we got closer towards implementation, did very intensive training with staff about what those new elements might be.
Mm-hmm. I think probably the most intensive training we had to do was around justifying clinical necessity. So you talk about people that have worked in the field for a long, long time, especially in the intensive residential level of care. You know, we did things a certain way, and people were there for months, and we really believe in that model, and I still believe in that model, but I also believe in a model where we have to justify all along the way that that is indeed the correct level of care for them, and that has legitimized, I think, our place in this world of treating people and providing them care in behavioral health, in medical world. I think that's legitimized what we do and how we do it, and I think that clinicians are stronger for it because they have to express what we're doing in clinically relevant and concise terms, what we're doing and how we're going about it, and what the client still needs to work on. And clients understand their work also in clinically relevant terms, that I came here, I've got these issues that I need to work on, they're psychosocial issues, they're ways to understand and navigate the world in a much more healthy way, and they know what they're doing and where they're going and how they're supposed to get there, and that they have to perform. They have to keep that level of care by working towards it, right?
That's helpful to talk about that in that context, but also recognizing that as we're shortening the length of stay, it's so much more critical to utilize that time in the most effective ways possible.
Yes.
So for us, I think the implementation of additional evidence-based programs, of other things that would we knew probably impact the quality of care and the ability to make it a much more comprehensive package in a shorter amount of time was essential to helping the staff buy into this transition. They had to understand we were also focused on the outcomes occurring in a much shorter length of time. We weren't changing some of the outcomes, but we were shortening sometimes the goal and the focus of the goal that the client might accomplish, because historically, if you were in program 6 to 9 to 12 months, there would have been many opportunities to do things educationally and otherwise, which now would occur after this level. This is also a model where person-centered care is so critical, and that's, I would say, somewhat different than the historical intensive or other levels of residential care. It's not that there wasn't a person focus and personal goals, but it's very person-centered. So your program is designed around the client's needs as opposed to the client being designed around the program. And so one of the things that I think has helped us to shift that has been really helping to identify and prioritize the client's interests, needs, and goals, and therefore their participation in the various elements and services that we'll have to offer will be targeted for that client, as opposed to everyone participates in everything and that it's a program and that you just come and participate. And I think that's a different mindset than used to exist in the previous 819 service that we offered. So one of the things that it helps to educate the staff on that transition and how you might use that, and have some good tools to do it. We actually created some tools that would allow us to, right from the very day that the client walked in, start to target those down and help the client start to look at ranking what's the most important priority for me, in addition to coming in and dealing with their primary addiction, but what other things were the most critical that they needed to address in order to be successful when they leave.
I agree. And you know what I like about the person-centered piece of it, and how that interfaces now with clinical necessity and managed care organizations kind of hovering over, as they should, because they're paying the bill, to say, how are you helping this person progress? Is person-centered is, what does the client need based on the skills that they have and the skills that they don't have? And sometimes clients come in and they want certain things, but they're not ready for those certain things yet.
So to segue to another sort of aspect of this, one of the things around staff development for us was really helping our staff learn some new evidence-based programming focused activities. And that was, I would say, a real developmental process. It takes some time to plan that out, to give them enough time to start implementing. We actually selected to implement those in our existing 819 programs in a variety of cases, so that it wouldn't be a complete comprehensive shift for the clients, but they were incrementally getting some of those evidence-based programs before we implemented. And we found that to be very helpful because it also helped the staff become more comfortable. But I would say that assuring you have left yourself enough time to do all that staff training, because that really encompasses a large number of staff. And so those were, I think, really important elements to help us be ready for the actual practice that was going to take place in the 820.
Absolutely. I mean, if you have an opportunity to train people and do dry runs on stuff before you actually go live with an 820, you definitely want to do that, because once you go live, it's not time to practice, it's time to do, right? And you talked about incrementalness of the evidence-based practices, and it's a key word because really the length of stay in a rehab has shortened drastically, I think, for some people, because it's a compressed treatment track. People have to go in and work harder, I'll say. It doesn't mean that they weren't working harder before, but they have to be much more focused on making progress now, and they have to really demonstrate that they had deficits, that they've made progress, that they could do it consistently. And so with the evidence-based practices, it's incremental in that they're going to make progress along the way, but they're probably not going to achieve all of it by the time that they leave, because they have to carry some of that then and keep working on it in outpatient, right?
Very true. You know, I think, and the more that we can do to help our staff be prepared, the more likely we are that they can remain with us as we shift to this new approach to treatment, these new levels of care and elements. I mean, one of the things we are certainly trying to work with and manage is both recruitment and retention. And this is a very challenging time in our field. There's many competitive forces, as you and I have chatted about in other conversations, that there's managed care, there's all kinds of other services that are really looking for the same population of clinicians and other staff, medical staff that are now heavily embedded in these services. So we actually started to do a tremendous amount of reach out to the medical schools, to some of the nurse practitioner programs, other places that we might have had some level of relationship but not as sophisticated or as connected as we are now. And that has helped us dramatically with recruitment of some of the medical staff. Also being aware that you have to be competitive. So salaries are very significant when you're dealing with people that have many, many choices about where they want to work. So I think all of those things, and having a variety of approaches to engagement with staff, and I know your program in particular has a lot of those types of opportunities.
We do a lot of things to try to recruit people, to keep them engaged, and to keep them vested in the mission of the program. And salary is important, and future career tracks for people is important. Right. But it's also, I think it's important to keep in mind, and I draw a little bit of comfort from the notion that people don't get into this field because it pays a lot of money, and they don't get into this field because it's sexy work, because it's not sexy work. It's really hard work, but it's also rewarding. And I think one of the things that keeps people engaged is being able to point out the small wins to them. And just like we have to point out the small wins to the client, right, to keep them engaged and keep them motivated, look at what you did today. I know you want to be over here, but you did these things to get yourself toward that goal. We do that with the staff as well. Like, that a client showed up at work for their appointment is a huge win when you knew how much they were struggling. So celebrate that win, and celebrate that win with them, and it gets better. But we overlook all that progress, so we have to keep pointing them back to, do you realize what a big step that was? Do you realize how much difference that made to them? And they're like, yeah, it really did make a difference. Yes, it made a huge difference, and it keeps people going.
And thank you for sharing that as well, because we are still, I would say, a little bit further behind where you are in that process of educating staff. But it is a very significant transition, even for very seasoned, licensed clinicians who might not have worked in an element where you have to justify and document so carefully and so clearly what you're doing and the progress the client is making, and all of the aspects of their care. And that was sort of a learning experience for us, that the medical team was just as critical as the clinical team in making sure we were communicating that entire message. So I think that's a very critical part that you might want to talk about, how your teams will work together to provide that information and assure that it's a clear picture for managed care.
Right, and inevitably, I think the clinicians who are now being asked to write things differently and express themselves differently, I think they end up feeling like they weren't doing their job right, or now I'm not doing my job right. And it's really, what I said to them is, it's no different than when we moved over to an EHR, right? We all of a sudden we had to navigate the forms differently, and it slowed them down, and they weren't as fast and they weren't as effective. But in time, they got used to the change, and they were able to move right along. And the same thing has happened with them. They were able to modify how they wrote things because that was what the insurance company was looking for. They certainly didn't say things that weren't true. They just said it in a different way that insurance companies understood. And that's just made a world of difference for them too, because they're happier now, right? When the whole change happened, they were, gee, I don't know. I want to do what's right for the client, and they should be here. And well, if they should be here and you want to do what's right for the client, then we have to learn how to express ourselves in a way that the managed care company understands. And likewise, they need to understand what we're doing and what we mean. So we have to be able to communicate in a way that we have a mutual understanding. And that helped move things along.
So part of, I think, the question would be, what has been the benefit of this whole process, because there's so many challenges and there's a lot of barriers we overcome to try and get to the end point. And actually, I don't know about you, but we're still trying to overcome some barriers
Sure,
in
absolutely.
various areas, logistics sometimes or other things. But one of the things that we have recognized has been the tremendous benefit to some of our, especially some of our most complex clients that we might have been serving in the past or might have tried to serve in the past, with just some really significant medical complexity, psychiatric complexity, clients with eating disorders and other problems that we just as a system were not as effectively able to manage in addition to their primary addiction. And I know for us, we've been able to stabilize people that we just believe without the resources of this new level of care would not have been successful at doing. And for a client who might never have been able to manage their diabetes, that they have consistently been in and out of emergency rooms, this new service has really changed their life. And we have some clients who are near completion, some who have completed, that we just never would have been able to manage before. And so from my vantage point, that was one of the reasons we wanted to be an early organization in this process, because we knew of some of the client needs. We had been serving for some time and not have the medical staff, not have the psychiatric staff to really be able to wrap around them and assure that we were helping them get the right medications, helping develop plans, safety plans, and other kinds of things that have really changed for us in this level of care. So when I think about why to do this, to me that's the biggest reason, is because I'm seeing clients who would have probably never been able to be successful have an outcome that can change their lives afterward.